Hello, everyone, and thank you for joining us. My name is Mackenzie, and I am the Community and Provider Education Coordinator for NAMI Maryland. I will be the moderator for our webinar today, along with my colleague, Gabby. Depression is a serious, potentially life-threatening condition that affects more than 17 million U.S. adults annually. There are many effective treatments for depression, but misconceptions about types of treatment and how to access them can cause dangerous delays in care. Today's webinar is supported by the William S. Perper Foundation, and we are hosting two special guests, Dr. Alexis Hammond and Dr. Dan Hale, who will discuss effective treatments and dispel many of the myths surrounding the diagnosis.
Before we get started, we wanted to note just a few housekeeping points. To avoid background noise, all participants will be muted for the duration of the webinar. This webinar will take the format of a question and answer panel. Due to the popularity of our webinars, we wanted to provide additional time for questions from our audience. Mackenzie will be asking previously submitted questions for Dr. Alexis Hammond and Dr. Hale to answer. We will be addressing any live questions at the end of the webinar. If you have any questions as the webinar continues, please enter them into the questions box, which is located on the right-hand side of your screen if viewing from a computer, or at the bottom of your screen if viewing from a phone. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask our speakers to do so when the question is asked. If you have any comments or concerns during the webinar, please also enter these into the questions box. We will review and address any immediate needs as they occur. A recording of this webinar will be emailed to each registrant tomorrow. The recording will also be available on our website at www.namimd.org for any individuals that were unable to register. Continuing education units are not available for today's webinar. A certificate of attendance will, however, be sent to each registered participant tomorrow afternoon. After the webinar today, you will be asked to complete a short survey on the aspects of the webinar that you felt were helpful, could be improved, and what you would like to see in future webinars. Each person that completes the survey will be entered into a drawing to win a $25 Amazon gift card. This is only one webinar in a series of educational webinars that NAMI Maryland plans to host. Our final webinar in our depression series will take place in March on the topic of beyond treatment, supports, and strategies. We ask that you please fill out this survey to let us know how NAMI Maryland can best support you during this time.
I'd like to now welcome our speakers for today's webinar, Dr. Alexis Hammond and Dr. Dan Hale. Dr. Alexis Hammond is a Spelman College alumni and graduate of Meharry Medical College and Georgetown University School of Medicine. She completed her residency in psychiatry and a fellowship in addiction research at the Johns Hopkins University School of Medicine, where she is currently an assistant professor of psychiatry and behavioral sciences. Clinically, she serves as the Associate Medical Director at the Center for Addiction and Pregnancy and Addiction Treatment Services. Her clinical and research interests include identifying innovative and efficient treatments for substance use disorder and other psychiatric disorders, especially among special populations such as pregnant and parenting women. Dr. Dan Hale is a special advisor to the president of Johns Hopkins Bayview Medical Center and director of the Healthy Community Partnership. He also is an assistant professor at the Johns Hopkins University School of Medicine, with appointments in the Department of Psychiatry and Behavioral Sciences and the Division of Geriatric Medicine and Gerontology. Prior to assuming his position at Johns Hopkins Bayview in 2011, Dr. Hale was a professor of clinical psychology at Stetson University. He is the author of several books, including Depression, Out of the Darkness, and Into the Light. In 2016, he was named Mental Health Professional of the Year by NAMI Metropolitan Baltimore, and in 2018, he received the Maryland Foundation for Psychiatry Anti-Stigma Advocacy Prize. Thank you so much, Dr. Hammond and Dr. Hale, for joining us today. We will go ahead and get started with our submitted questions from our audience. Our first question is, can you discuss the latest pharmaceutical and psychotherapy approaches to treating depression?
Sure, I'd be happy to answer that. So I think some of the more classic medications that we think about for depression include kind of those known as antidepressants, especially those selective serotonin receptor inhibitors, or SSRIs. Essentially, that class of medication just works to increase the kind of good chemistry in your brain, the serotonin. And so those are some of the more classic depression medications. Some of the newer medications tend to work on other chemicals in the brain, like dopamine and norepinephrine, all with the goal to try to boost your mood. And so medications like Trintellix would be a newer one, kind of similar to that. Another kind of new and big therapy is ketamine, that some people might have heard of, which works on one of the chemicals in your brain that kind of gets the brain excited. And so it's a little bit different than more classic antidepressants, and it's given IV about once a week to start. And it actually works a bit faster than some of the classic antidepressants that you take by mouth every day. Those tend to take 6 to 8 weeks to see the biggest effect. And so ketamine is different in that it works faster, but you have to take it, weekly IV, so kind of in a clinic, being supervised. In addition to that, some people may have heard of TMS, or transmagnetic stimulation. Transcranial magnetic stimulation, which essentially serves to change some of the kind of brain waves or electricity that you have in your brain, in addition to the chemicals in your brain, to help improve depression. And so that's also done in a clinical setting in a very safe manner. Now, I can also discuss ECT, which is definitely not new, but that's another way to use kind of a non-pharmacological method or non-medication to get people feeling better faster, and also kind of gives you like a bit of a electric shock that is very safe under anesthesia, and your body is relaxed. And so it's much different from what we may have seen 50, 60 years ago, especially in the movies. Very safe, very effective. And certainly psychotherapy is definitely important, and that's not new at all either, but definitely want to mention that. And I think Dr. Hale can go into that as well. But so those are some of the big ones. And then there's a new medication for postpartum depression that is called brexanolone, or Zulresso, and that is also given IV. And so that's pretty exciting to help that population, which can be very debilitating.
Okay, well, let me say a few things about psychotherapy. Psychotherapy, or talk therapy, has been found to be effective for depression, particularly mild or moderate depression, and sometimes combined with medications for moderate to severe depression. Two of the well-established evidence-based therapies you might have heard of. One is cognitive behavioral therapy, where the goal is to identify and then modify negative thought patterns and negative behaviors. What you find with depression, of course, is usually some very severe distortions about a person's past and their present situation and the future. And so this sort of therapy really zeroes in on those, as well as often you see the changes in behavior where they're not doing the things that have really been reinforcing and gratifying in the past. So that's cognitive behavioral therapy. If the depression seems to be related to losses through death, divorce, or troubled relationships, or new roles and responsibilities, then interpersonal therapy is another one that is well established and effective. And sometimes you'll hear the term eclectic, which means sort of blending or taking parts of two or more therapies to work together. So anyhow, there's good news about the psychotherapies along with the medications.
It's wonderful that there's so many different treatment options for each person that's struggling. And I think it's important to note that every treatment is individually based, and some treatments might work for one person and some treatments might work for the other. Thank you for that. Mm-hmm. Our next question is, do I have to see a psychiatrist to be treated for depression, or can my primary care provider prescribe antidepressant medications?
So primary care providers can certainly treat depression, and a lot of times they are the first ones to identify or diagnose it or treat it. So certainly mild to moderate depression can be treated well by primary care providers. You know, if you're getting to the point where you have tried maybe several different medications and they're not working, perhaps talking to your primary care provider about whether it may be time to go to a specialist at that point, you know, seeing a psychiatrist at that point, or just very severe depression where you may have thoughts about wanting to end your life. If it's so bad where you can't eat or that kind of thing, then you may want to see a specialist. But certainly you could start with your primary care doctor, talking to them about options for medications and also potentially getting a referral for them.
Absolutely. Dr. Hale, do you have anything else to add to that question?
No. I think
You answered it pretty well.
Well, the other thing I want to just add to that really quickly is I was mentioning for major depressive disorder, but sometimes when people have depression from, say, like bipolar disorder, for example, some primary care doctors might not feel as comfortable treating that, and so that person may need a psychiatrist, for example.
Perfect. Our next question is, how long will it take for antidepressant medication to help me feel better?
So our medications, like I was mentioning before, can take some time. The medications that you take by mouth every day, you may see some improvements in 2 to 3 weeks, but to really see that full effect of feeling much better, it's really, you have to give them a chance. So you have to give them like 6 to 8 weeks to see that full effect. And that's something I have to remind my patients so that, you know, they don't want to give up too soon, that it does take some time. And so using the psychotherapy in addition, especially during that time as the medication is getting up, is very important.
Absolutely. What are thoughts of suicide on the warning label for some antidepressants? Or why are they on there?
Yeah, so, you know, drug companies have to put every single possible side effect on every medication, not even just antidepressants. There are some groups who may have higher rates of suicide when they're starting a depression medication. One group in particular are those people who have bipolar disorder, as I mentioned. So traditional antidepressants sometimes make them feel worse. And so it's good for you to be able to be open with your provider about your symptoms so that they can diagnose bipolar disorder and treat you with an appropriate medication to try to avoid any worsening of your depression. So that's one group. The other thing is that, you know, like I just mentioned, it takes some time for the medication to really work. And so some of what we have seen that has caused that warning label is that people just weren't on a good dose yet of the medication, or they hadn't given it enough time. And so it was really the depression that was causing those suicidal thoughts. And it was just associated because they happened to be on an antidepressant, if that makes sense. So the antidepressant didn't necessarily cause the suicidal thoughts. They just were on it, but not at a good dose, or hadn't been on it long enough to see an improvement in their mood. And so again, talking to your provider about whether antidepressants are right for you is really important. Any symptoms that you're having, and also, you know, kind of letting them know during that time while you're getting onto a good dose of the medication.
And what are some other common side effects that you had touched on besides suicide?
Yes, I would say that suicide is not common, but some of the more common things that we see is sometimes people may have a little bit of stomach upset when they first start a medication, especially the SSRIs or selective serotonin receptor inhibitors. But if you give it a few days, that tends to go away, that stomach upset. So sometimes we may start at a lower dose and, you know, over a few days, increase the next dose to try to avoid that stomach upset. But that is the major side effect that I will warn my patients about. Some patients, and not all, some may have sexual side effects related to that. So just important to talk to your doctor if you're having any of those. And also, again, trying to tease out what what's from the depression and what's from the medication. What else? It really just depends. For the most part, these medications don't have a lot of side effects. They're overall pretty safe, but every person is different. But those I would say are the most common that we might hear about.
Thank you for sharing that, Dr. Hammond. It's really important to know what's going on with your body and make sure to talk to your physician or your primary care about those problems that you're experiencing. What should I do if the prescribed medication isn't helping with my depression?
So I would say definitely talk to your provider about it, especially because maybe you need a higher dose, like I mentioned, or maybe it just hasn't been long enough time that you've been on it. And so really talking to them about whether you've given it a good try, or if it's time to perhaps switch to another medication. But I would certainly recommend talking to your provider before discontinuing anything, just because of those reasons. You may just need more time. And also sometimes our medications, depending on what it is, sometimes you have to come off slowly instead of just stopping kind of cold turkey, if you will. So yeah, there are multiple options. Sometimes the first medication won't work for everyone, so I would definitely say work with your provider to find what's right for you.
And is antidepressant medication addictive?
So they are not addictive. The only thing that I will say is, like I just mentioned, some antidepressants, and not all, you just have to come off slower, because when you stop at a high dose right away, your body can kind of, it's just like a shock to the system. So they're not addictive in that you are going to like take more than you need or anything like that. They don't have any street value, anything like that. But you just may have to come off them a little bit slower than other medications, depending on which one you're taking.
And how long will someone need to stay on their medication? Will they have to be on it for the rest of their lives?
So it depends on the person. Depression is, and all mood disorders, whether it's depression or bipolar disorder, they are what we call episodic, so they can come and go. But they are chronic illnesses, just like diabetes can be, or high blood pressure, things like that. And so for those kind of medications, you continue to take them so that you will stay well. And it's the same case with antidepressants for the most part. Very few, some people may have one episode and maybe not have another one for a long, long time, but for the most part, you want to continue to take your medication to prevent having episodes from occurring, especially when you have a pretty severe episode. But again, you can talk to your provider. Maybe you are someone who may have a milder depression, who may be able to come off and see how you do, perhaps continuing in psychotherapy in the meantime. But certainly for those who have very severe depression that is really affecting their functioning or making them want to have suicidal thoughts, then I would say they should continue on their medications as part of their wellness plan.
So can I add something from both a professional and personal perspective here? One is although I do not prescribe medications as a psychologist, not a psychiatrist, not a physician, I very much believe there's a role for them. And one of the things that concerns me sometimes is, it seems like patients want to get off them as fast as they can. So as soon as the symptoms are gone or mostly gone, they think they should just go off them. And I know that's not wise. I believe at least 6 to 12 months beyond that is advisable. From a more personal perspective, some people know I've had 2 episodes of depression. The first one responded immediately to the medication that was prescribed. Had those, a couple mildly unpleasant side effects that dissipated very quickly, and so that was fine. And I stayed on it for a number of months, and then in consultation with my doctor and therapist, decided it was safe to go off. And I spent the next 15 years or so doing just fine. But the second episode came on. I actually, at that point, They tried me on a new medication that didn't work. So it actually brought on anxiety. And that was a case where I went from my primary care physician to a psychiatrist because I needed to get a little more precise on that. And she prescribed a medication that worked very well. And one of the side effects of that medication is it's very sedating, which is good for me because I want a good night's sleep. But also then, after being on it a while, discuss, how long do I stay on it? And in consultation with my psychiatrist, I decided to stay on it indefinitely. So there's no harm to any of my other conditions or any interactions with other medications. So I certainly believe, you do not want to stop unless you really feel very confident and have a good plan in place.
Thank you for sharing your experiences, Dr. Hale. Dr. Hammond, I know you have had specific work experience with pregnancy and parenting women, so I believe this question is directed towards you. Can you stay on track with mental health treatment through medication while pregnant?
Absolutely. So I always tell patients who, are in the reproductive age, if you will, the best thing to do is to plan the pregnancy and work with your provider to make sure you're already on a good medication that is safe in pregnancy. However, 50% of pregnancies are not planned. And so, still I would say continue on the medication if you find out you're pregnant and talk to your physician about whether it is safe. Most of our antidepressants are safe in pregnancy. And so it's another time where you really want to weigh the risks and benefits of taking the medication versus not. So especially if you've had a severe depression, it's likely that you would need to continue on it to prevent an episode from occurring during pregnancy and to prevent postpartum depression so that you're able to take care of yourself and your baby. Certainly, if there's a mild depression that you've had, you may talk with your provider about doing psychotherapy alone during pregnancy. But again, I would say it's a discussion with your provider. There are a lot of safe medications that can be taken during pregnancy. And then there's also the risk that depression has on the baby. So depression itself can cause, adverse effects on the pregnancy, such as low birth weight and preterm labor, those kind of things that we want to try to avoid. So it is, again, the risk benefit kind of discussion as to what's the right thing for you.
Thank you, Dr. Hammond. Our next question is, what professionals are trained to provide psychotherapy?
Okay, I can take that one. There are about 5 different professions that are trained to provide psychotherapy. I'll start with psychiatrist, but also, and Dr. Hammond can comment on this, although psychiatrists are generally trained to provide therapy, my impression is that most are focusing on medical treatments and generally referring on or working with other psychotherapists. Does that seem to be true, Dr. Hammond?
Yeah, I mean, at Hopkins, we all do psychotherapy, but I do think it depends on the person themselves, whether they choose to do it or not. But we all get trained in residency, at least, but not every psychiatrist does psychotherapy. Yep.
Yeah. The other professions mental health professions would be psychology, clinical psychologists who are doctoral level professionals. You'll generally see either a PhD in psychology or a PSYD, a doctor of psychology. Another established health profession that provides psychotherapy are licensed clinical social workers, generally again well trained, especially if around family issues and stressors in life, be very good. There's another group of, and the terminology may change from state to state, but it's mental health counselors, licensed mental health counselors, licensed professional counselors. Again, these professions not only have a good amount of coursework, but also a lot of supervised supervision before they're allowed to function independently and get their license. And then also psychiatric or mental health nurse practitioners. So those are I think I've covered those are all the professions that you'd be looking for.
It's perfect, very helpful for when people want to seek out treatment. Our next question is, what is the best way to find a psychotherapist? You mentioned all the different positions, but how would they find someone?
I'll start, and Dr. Hammond can add in some. I think often your primary care provider is a good place to start. I mean, I think if you're experiencing depression, your primary care provider should know what you're going through, whether or not they are going to prescribe medication or refer you on to a psychiatrist, but they may have some good referrals. You may want to start with your insurance plan, see who's on that plan, especially if you're going to depend on insurance to cover that. A lot of organizations also have an EAP, an employee assistance program, and those typically will provide 2 or 3, maybe a few more short-term counseling sessions during the sort of period of greatest need, but they also would have referral sources. If you're a member of a faith community, often clergy are well-versed in terms of who would be available in the community. Certainly family, friends, a good word of mouth referral is usually very helpful. Someone says, this person really helped me a lot, or I know they helped somebody else. If none of those are available, there is a website that you can go to. It's psychologytoday.com. And what's nice about that, it has a large number, and you can filter it by location. Are you in Baltimore, or are you in another part of the state? And you can also filter in terms of what the specialty is. Does the professional focus on depression or anxiety or ADHD? What sort of things? Do they take insurance? What their fees are? What their credentials are? So that's another place to go. Dr. Hammond, you may have some other ideas.
I would absolutely echo everything you just said, and especially Psychology Today, for people who have certain issues that you are looking to get therapy for. You can search by that, whether it's certain ethnic communities or LGBT communities. You can search for men versus women, people who look like you, that kind of thing. So I definitely refer our patients to that website. But if you have a psychiatrist already, the other thing is you could see if they work with someone who accepts your insurance, so that you can have that kind of continuity of care, or having your providers communicate with each other, which should happen anyway, but it's a little bit easier when they already work together.
Absolutely, and I can also speak to NAMI Maryland as well. We do have a helpline for anyone who is wanting to be connected to different resources in their local community. So while we don't refer to certain psychotherapists, we would be able to connect you with organizations that would be best supportive. Our phone number is 410-884-8691, or you can also email info@namimd.org, and I'll provide that information at the end of our webinar today as well. So our next question, we talked a little bit about how long medication takes to help us feel better, but how long does it usually take for psychotherapy to help someone feel better?
So usually to have, to really feel a pretty full effect, it's probably going to be at least 6 to 8 weeks. But, excuse me, I think I have found, both as a patient and as a therapist, that there's usually some immediate relief felt. You've been going through this terrible experience, and you feel shaky and uncertain, and to be able to sit down with someone and to share what you're going through, and that professional understands what you're going through and can offer some encouragement, saying, this is something that is treatable. Depression is treatable. Often people walk out of that first session or two with a sense of relief. Okay, at least I now have a plan. And then you slowly gain confidence and become more hopeful. And then, hopefully by 6 to 8 months, 6 to 8 weeks, maybe a little bit longer, most of the symptoms are gone. The person has sort of recovered their confidence, their enthusiasm, their ability to enjoy life. If you're not having, I'm just adding, if you're not having a good effect if you're not having some good effect by 6 to 8 weeks, you need to make sure you share that information. You may need to add medication if you're just relying on psychotherapy. But certainly by 10 or 12 weeks, you should be feeling much better. And we've used the term psychotherapy it may be a place you want to start with mild to moderate. With severe, then certainly you want to be looking at the medical route too.
Dr. Hammond, do you have anything to add to that question?
Sorry, trying to unmute, but certainly I agree with everything you said.
Okay, perfect. Our next question is, how confidential is psychotherapy? Can therapists share personal information with members of my family?
I can give a quick, well, everything should be confidential. Anything that you share in therapy with your therapist should be treated as confidential, not shared with anyone, with one, possible two exceptions. So the main exception is if the therapist determines that or believes that you are of immediate danger to themselves, to yourself, or to others, then not only may they have a responsibility, we call it a duty to protect. So if someone shares information, I'm planning to go kill myself, or I'm ready to go out and harm someone else, then that information would have to be shared. The other thing is if in therapy you hear about any sort of abuse or neglect of children or elderly or disabled. But basically, those are the two exceptions. Otherwise, it's absolute confidentiality. And that's an essential part of therapy.
Our next question is, how do I encourage a loved one to seek treatment and take their medications?
So I can comment on that. I think that often when someone is feeling depressed, they may not necessarily realize how different they are from their kind of normal self. And so pointing those things out in a loving way, you seem like you're not yourself. I care about you and I want you to get the treatment that you need for this. It is a very treatable illness. And so I think encouraging the person to get the help they need, or even taking some of the steps, when you are depressed, it's very hard to have that motivation and concentrate to even be able to be organized enough to find a provider if they don't already have one. And so I would say, those kind of things would be very helpful for a loved one to do. And, just I think we all know that there's a certain stigma associated with some of our disorders and their treatments. And so just being open with them and making sure they know that there's nothing wrong with them per se. It's an illness, just like anything else, like cancer, for example, or heart disease. It's an illness that they didn't do anything to deserve. So I think as long as, having someone else who is telling them that it's okay to get treatment would be very helpful.
I think just to add, so I agree absolutely, and especially the stigma issue, which, to let them know you view this the same as if they had diabetes, the same as if they had hypertension. So no reason to feel bad about it. And I think, but also, I think people who are on this webinar today are doing the right thing in that trying to learn as much as you can about depression so you can understand what the resistance might be, because also at the heart of depression is pessimism. And, where you're thinking so clearly, they may not be, as Dr. Hammond said, be thinking so clearly. And so to understand depression enough and treatments enough to provide that ongoing encouragement, with time, with treatment, people recover from this terrible illness. So the more you can inform yourself, I think the better you can help others. And NAMI, of course, is a good place to learn more.
Absolutely. We have a family support group as well as a family-to-family program to learn more education as a family member, and it's led by family members themselves who have been through what you've been through as well. Our next question is a little bit more involved into what a loved one can do, but it's how do I know what to look for to know if there is a problem?
Yeah, I can take it. Well, so again, the person is different than how you normally see them. So they may not be interested in doing certain activities, maybe sleeping more or not sleeping at all. They're not eating as much or eating too more. I mean, not eating as much or eating too much. Those kind of symptoms would be consistent with depression. And maybe you've seen them depressed before in the past, and you know that they can get better. And so those are some of the main symptoms to look out for, or even substance use, increasing alcohol, and certainly right now, especially we're still dealing with this pandemic and everything else that's going on in the world, and so a lot of people may be more stressed and anxious and depressed during this time, and when you're not able to kind of do the things you normally do and function as well as you typically can, that would be the time, I think, to reach out for help. Even in this situation where it kind of makes sense that we may not be feeling our normal self, it's still helpful to get some extra support in therapy, but especially when you see a person is not doing well and there's really no kind of clear reason, no particular stress in their lives that would be causing it, then it's more likely to be a clinical depression that would be the time to kind of reach out and try to get help for them.
And when can they tell if things are getting better, if they're getting worse, or when they might be in crisis?
Yeah. I mean, I can take that. I think in terms of one of the things that I generally see in depression is the person has lost the ability to enjoy things they previously enjoyed. And so, that's something I look for to hope that it's beginning to come back. So they're showing up at places, they're more enthusiastic, they're talking about, the positive things about the future. Where I get more worried is when they seem very hopeless, when they don't enjoy things anymore and they continue to withdraw, and especially when their attitude toward themselves turns negative, or so they're blaming themselves. It's one thing to be blaming correctly, the pandemic and how this has altered life, but when that then changes to I'm defective in some way, something is wrong with me, and I'm never going to get better. People would be better off. I mean, you get very alarmed if someone's saying, people would be better off if I weren't around anymore. Those are the things that really get me very worried, and they make me want to intervene, whether as a family member, friend, or as a professional.
Dr. Hammond, you had mentioned in a previous webinar the ability to laugh. Could you speak to that a little more?
Oh, yes. I mean,
I'm sorry.
Me or?
Dr. had mentioned it in a previous webinar.
Although she called your name, she's referring to.
I'm sorry.
Yeah, so what I related was that I really lost the ability to, again, appreciate humor or beauty or anything. And so one of the first signs, and a friend pointed out to me when they said something humorous happened, and I laughed, and they said, that's the first time I've seen you laugh in a long time. And I realized I just didn't, I could say in my head that was a funny comment or a funny joke or a funny program, but I couldn't really feel it. And so that sort of ability to begin to just enjoy part of life was the first sign I was on the road back.
Thank you for sharing, Dr. Hale. I know we touched on this a little bit with Dr. Hammond, but is there anything in particular that someone can say or do to help, and what should someone not say to help?
Yeah, I would say similar. Yeah, as I had kind of mentioned before and touched on, you know, making sure that they know it's not their fault that they're feeling this way, or that they might not be able to do things that they normally do. So, you know, some things that I wouldn't say, or just kind of pull yourself up by the bootstraps, or just kind of get over this. It's a disease that really needs treatment, and often it's hard to do it on your own, especially when you're feeling that depressed. And so just being supportive, like Dr. Hale said, educating yourself so that you understand the illness as well as you can. I think those are all important things, and encouraging them and providing some hope that they may not have.
Yeah, I agree. I mean, the last thing they need to hear is snap out of it, or don't you realize how lucky you are? Things like that show that you don't have any real understanding of it. And words like, I love you, I care about you, I want to help you. And then sometimes a friend related something just over the weekend where she'd been very down and depressed. And, a friend just said, I'm coming over. I'm going to, help you fix dinner and help you clean the house. And that just had a very powerful effect, that somebody really cares about me enough to, change their life to come over and help me. So
That's wonderful. Our next question, if I am struggling or know of an individual struggling with dual diagnosis of mental health and substance use, how can I seek or best support that person?
Right. So I would say if they are in a true crisis, sometimes you might have to call for help for them. And that's when let's say if they're intoxicated with substances and they're just not able to think clearly or take care of themselves, would be a time that they'd be in crisis. Or if they're, talking about death and wanting to hurt themselves, making plans for that. I would definitely reach out to some of the crisis lines that we have in the area. Otherwise, getting other resources for them if they're a little bit more stable but struggling with depression or substance use or both, which could be many different options: outpatient treatment, of course, residential or inpatient treatment as well. But first the patient really has to kind of want to do those things and get that help.
Can you speak to COVID-19 and its impact in terms of depressive symptoms, suicide, and the possible difficulty in obtaining treatment?
I can add something or say something there. I went on the CDC website just this morning to get the latest numbers. So CDC does what's called a pulse survey where they ask just a few questions. And when they did that a year ago, about 6.6% of American adults reported symptoms of a depressive disorder. So that was in 2019. Just a month ago when they did that, the number was 30%. So a tremendous increase in the what people are reporting in terms of symptoms of depression. Doesn't mean they were all diagnosed, but they answered the survey with questions. And certainly I think we attribute much of that to the pandemic, the disruptions, the isolation, and so forth. It's also been a period of social unrest and political turmoil, which I think also, my impression is that that's contributed to it. And on the suicide, I'll offer something, but I think Dr. Hammond and one of her colleagues, Dr. Nestat, really may be more up to date on this. But well, Dr. Nestat, who is a psychiatrist in the department, just published a study recently that found that suicide rates differed Black versus white. That in the pandemic, if I got this correct, the suicide rates in Maryland, which is where it's, well, I'm not sure where all was studied. Suicide rates for blacks actually went up, but for whites they went down. Does that sound right, Dr. Hammond?
I haven't seen that work, but I think it makes sense. I mean, what's been going on with the disparities and the pandemics, who's dying from the pandemic and racial injustice and everything like that. So, yeah, I think in addition to, as you mentioned, depressive symptoms going up, and there's more domestic violence occurring during the pandemic. People are overdosing more on substances, and substance use in general is increased, especially alcohol use, which certainly could be related to a lot of depressive symptoms and anxiety. And I think in regards to the difficulty in obtaining treatment, the pandemic has also kind of shed a light on difficulties and barriers to care when we're looking at telehealth, and not everyone necessarily has video capability or for video visits or access to the necessary Wi-Fi or devices, that kind of thing. And so, when most people are really doing telehealth only for the most part, definitely makes it difficult for people to access if they don't have the types of technologies that they need to do so. So another issue.
I know one of our questions that came through was just regarding the long wait times of getting help. Do you believe that's gotten worse through the pandemic?
I think so. Unfortunately, it was, their wait lists were long before the pandemic started. And so I think, it's even worse because more people need the services, and the services are limited to telehealth for the most part. So, unfortunately.
And what can someone do if there's a long wait list and they need help more immediately than the longer wait times? Would their best option be a crisis line, or what would be the best option for them?
So there are crisis lines, a national calling, suicide prevention lifeline is what they like to go by. And they make it clear that you don't have to be suicidal to call that number if you're in crisis. That's one option. There is a crisis text line as well. I think it's 741-741, and just type home or talk. There 211, sometimes the United Way 211 can help you find a resource. There are support groups, NAMI, and then also the Depression and Bipolar Support Alliance. And then in Maryland, there's a wonderful organization. I wish every state had it. It's called the Pro Bono Counseling Project. And that has more than 800 licensed therapists have pledged to take on at least one patient client who can't afford or either has no insurance or can't afford. So I don't know how quickly they can help you, but that's a good resource to be calling. And much like Dr. Hammond was saying, in terms of often you want to pick someone the same gender or the same ethnicity, so forth, they'll try and match you up that way too.
That's wonderful. Dr. Hammond, do you have any additional resources that you'd like to add?
Oh, I think those are all great resources. I think Mental Health for America is one organization, and I know they have a kind of a warm line, so that may be what Dr. Hale mentioned before. You can also text them. And for people in Baltimore Crisis Response is a good group as well. So.
And SAMHSA as well is good for substance use treatment.
Mm-hmm.
So we're going to go ahead, and I know that was a lot of questions to get through, but we also have quite a lot of live questions that came through. So I'm going to turn it over to Gabby so that we can go ahead and get started with our live Q&A.
Yep, so thank you to both of you for providing this information during this great time of need. So now we already have a bunch of questions, but we'd like to open up the webinar now for any other live questions that you may have. So remember that everyone will stay muted to avoid background noise, but you can type your question into the question box at the right-hand side of your screen if viewing from a computer, or the bottom of the screen if viewing from a phone. And if you have a question that you'd like to ask, or if you have a comment, you can please enter those into the questions box now. And if we don't have time to answer each question today, we'll provide our contact information at the end of the webinar for anyone who may wish to reach us. So this question kind of relates to the resources we were just talking about, but are there any resources, places, or organizations to find culturally adapted depression treatment models for Black, Indigenous persons of color?
So I agree with Psychology Today. It's a good place to look for that. And as I mentioned, you can type in what particular concerns you have in the search to see people who are culturally competent. For example, I think Mental Health for America has good resources on that as well. There are apps that are specific to certain racial groups, like Health in Her Hue is one for if you're looking for a Black woman, for example. I'm sure there's others that I can't think of right now, but certain groups, if you do like a quick online search, could also help with that. Like therapy for Black girls, for example.
We also have a section on our website at www.namimd.org with fact sheets directly related to this type of question. So if anybody is interested, I could certainly direct you to those fact sheets on our website.
And then to shift over about kind of the questions that were asked in the beginning, there are a few questions about brain changes in relation to medication and depression. So the first one is, could you talk a bit more about the long-term brain changes that are hypothesized to occur in the brain when taking psychotherapeutic medications?
Sure. So obviously the brain is very complex, but the goal really, as I mentioned, is to increase the serotonin levels, which are kind of, your the chemistry in your brain that kind of helps with your mood, makes you more happy, working with your endorphins, that kind of thing. And so in major depression, there are areas of the brain where those chemicals are lower. And so the medications are really just helping to kind of even things out to a more normal level, if you will, of the brain chemistry. So mostly serotonin, also dopamine, neuroepinephrine, stuff like that. Norepinephrine. But without changing the person's personality per se. The goal is really just to work on the mood in particular.
And then another related question, could you talk more about depression associated with traumatic brain injuries and any recommendations for those with TBIs?
So that's a good question. So, part of the reason that we know what areas of the brain are affected by depression are from different injuries to the brain that people have had and brain imaging that we've done. And so, certainly certain traumatic brain injuries can affect many different things, including your mood, but also your kind of impulsivity or sometimes your memory, things like that. And so there are certain medications that are more helpful for people with TBI, like Depakote, for example. But I would say talking to your provider about what's right for you, but also there are centers that are specific for persons who have had traumatic brain injuries. We do have one at Hopkins. I don't know what their wait list looks like right now, unfortunately, but I'm sure if they couldn't help you, they would be able to point you in the right direction.
And then what is the actual effect of ECT on the brain that may cause the individual undergoing it to have their depression improve?
Yeah, so after all this time, we don't know exactly what it does. But again, we do think it helps to improve some of that brain chemistry, like I mentioned, especially serotonin. But that was another thing that was kind of found serendipitously in terms of people who have natural seizures or epilepsy, and also have depression. We found in the past, many years ago, that their mood would improve after they had a seizure. Um, and so we were able to modify that over the years to do it in a safe and harmless way, to induce a seizure in the brain, using electrodes. And so, and again, that's one where you have to kind of go like every other day for several weeks to see an improvement. Some people will do ECT and then continue on antidepressants after that. Some people need to do ECT regularly to stay well.
So I'd just like to add that I want to endorse the role of ECT for certain depressions that haven't responded to treatment or where suicide is such a clear and present danger. And as Dr. Hammond mentioned earlier, the way it is conducted now, and I spent a day on the unit not too long ago, it is not at all as was portrayed in films or as it was in reality 50 years ago. So I would just have if I were to get seriously depressed again and it did not respond to medication, I would definitely opt for ECT, and I would definitely recommend it to anyone else. So I hope we can get rid of that sort of old notion that there's this terrible, painful convulsion that just looks, horrific. It's a very gentle anesthesiologist right there, anesthesia. And so I just want to say that that's an option people should consider if they're not getting a response to medication and psychotherapy.
So there are a few questions about depression linked with other disorders. One of them is the link between sleep apnea and mood disorders, as sleep apnea may make depression-like symptoms worse.
Yes, so sleep apnea can cause a lot of effects in the body, including worsening your mood. So it's definitely important to get that sleep study, see if you have it. If you do, using the treatments, I know they're not always the most comfortable, in particular, having to wear masks and having that pressure on your face, but it's definitely important for having more energy throughout the day, improving your mood. Sleep apnea is not good for the heart, so many different things. So, there are many medical diseases that can cause a low mood, and that when you treat the medical condition itself, your mood can improve, like having a low thyroid, for example, other hormones that are affected or low vitamins can cause low mood. So if you have your first depressive episode, it makes sense to make sure you have a good workup to make sure that nothing else is going on medically, and that it's actually caused from the brain disease itself.
Now I have a few questions about providers getting help and like different types of therapies. So the first one is, many psychiatrists or psychologists are not covered under Medicare or do not accept Medicare and require private pay, which can be unaffordable for many. So how do people covered under Medicare get needed help?
So I had mentioned one before, the pro bono counseling project, at least for psychotherapy, is an option. That's exactly what they're set up for people who don't have insurance coverage or can't afford it. And then I don't know, I know some therapists offer sliding scales, something else you can explore going on websites, maybe psychologytoday.com. I wish I had more answers, better answers, but those are the two I would go with.
Yeah, and I would agree with that in saying also contacting Medicare either by phone or via their website to see who may be in your area that's taking that insurance. And also in Psychology Today, as mentioned, you can search by what insurance you have as well.
And then what kind of psychotherapy or treatment plans may work best for depression caused by trauma or sexual abuse?
I don't know. I'm very much a believer in cognitive behavioral therapy, but often, so I say that, pause a little bit. Sometimes people think that therapy for depression really is simply venting, where people go in and just unload, or they believe that it's going to be long term, always delving into childhood, so forth. And so most of the therapies, certainly the two I talked about, interpersonal therapy and cognitive behavioral therapy, while they don't ignore the past, they focus more on the present and the future. But even when you start there, if the issues clearly are related to trauma, then that's where a good therapist is going to go. So you might hear talked about more psychodynamic therapy or supportive therapy, but I think that would just be a part of both interpersonal or cognitive behavioral. And again, on that, we keep pushing. We don't get anything for promoting psychologytoday.com, but again, that filter. So when you look at it, some therapists say depression, some talk about trauma and depression and so forth. So that's a good place to do some searching.
And then another question about types of therapies. Do you support the idea of group therapy or peer-to-peer therapy for family members?
So, okay, it sounds like two questions. So one, I think for my experience has been most depression one-to-one for a lot of reasons is best. In addition to that, can group therapy be helpful? Sure. And do I think it's good for families to educate themselves or to even be a part of a support group? Caring for someone who is seriously depressed is a very challenging thing to do. It's very draining. It can be hurtful. And so I always say, if you have a loved one who is going through a serious depression, don't try and do this by yourself. So I think, again, to learn everything you can, to make sure you have your own support system. Family education is good. Support groups are good. I recommend all of those.
And then, can recreational therapists play a role in recovery?
That'd be more part of inpatient, wouldn't it, Dr. Hammond? Or
yeah, that's where I usually see kind of art therapy, but yeah, sometimes occupational therapists can in the outpatient setting, but certainly whatever works for the individual. Some therapists do some art therapy as part of their kind of different therapies that they do. And so again, like you said, we don't get paid by Psychology Today, but you can also search for that.
I know in my experience as a social worker, art therapy can be exceptionally therapeutic and just allowing people to talk in a way that's most comfortable for them.
Well, I'll throw in something else, which is, there is evidence for what's called bibliotherapy. Cognitive therapy, cognitive behavioral therapy, the work started with Aaron Beck and another psychiatrist, David Burns, picked it up a lot. If somebody, is really willing to take the book and really follow it and do the advice, often that can produce really good changes. So that's another option I often don't think to recommend, but I know the book called Feeling Good by David Burns has been helpful to a lot of people.
I think those are most of the questions I saw that stood out, unless Mackenzie, you found any others, but there were also just a few about like other studies and resources that you guys would recommend, or also questions just related to like COVID and everything going on, but we kind of talked about that stuff.
Well, let me mention one thing. So I think people can, with confidence, go to the NIMH website, National Institute of Mental Health. They do not accept any advertising. They give you the latest research and reports. The American Psychiatric Association also has a site for family. American Psychological does too. So there are places to go get that information. And on medications, I often refer to Medline Plus as a place you can go. Again, it's a NIH, National Institutes of Health organization. So again, not being influenced by advertising dollars.
Absolutely, and I know that we are running over our time here today, and I do want to be respectful of our attendees and our speakers, but I did have one question that popped out to me. Was a lot of the time people struggle with finding the right person to talk to, and someone had asked if you can give examples of questions to ask when interviewing a potential therapist to see if they're a good fit.
So I'll offer something. I'm sure Dr. Hammond has some advice too, but I think it gets at a very important point, which is therapy. You need to have a good, what we call therapeutic alliance. It's a collaborative process, and so you do need to feel good about the person you're working with. So I would say ask any question, any concern you have. You know, and the one that I sometimes bring up, sometimes people feel is that if I'm a very religious person, is my therapist going to respect my religion, or are they going to look at that as sort of a part of the problem? So I would say any concern you have, whether it's around confidentiality, how they view, you know, societal issues, religious issues, because you have to have that level of comfort where you can feel comfortable going in and just saying anything, knowing you're not going to be judged, you're not going to be criticized, so forth. So any question would be a good one.
And this pertains mostly to the physical and mental wellness aspects. I know physical health is very important when you're discussing your mental wellness too. So what role does food play in mental illness, as well as weight gain and healthy eating? Can you speak a little bit to that?
So since depression can cause low energy levels, I think anything that can affect that also is going to make things worse. And so I definitely recommend patients have kind of a well-balanced and nutritious diet that are getting some activity in. It's again hard to kind of get up and get active when you're not feeling well, but it really does help when you are getting some exercise in and activating yourself. And so I really recommend people push themselves to do something, get up and do something if they can. So right, and so making sure your vitamin D levels are good, like all of that thing, all those are gonna play a role into your energy and your mood. So I think, you know, really taking a holistic approach is important.
Absolutely. Dr. Hale, do you have anything to add?
I would reinforce what Dr. Hammond just said. I mean, I think people need to engage in self-care. I mean, sometimes you need medication, sometimes you need therapy, but you also need to do the wise things. When in your most lucid moments, you know that you should go ahead and get up on a regular routine. You should get some exercise, even if it's just walking around the block. You should eat well. You should reach out and have social relationships. So try to get yourself back in that direction.
Yeah, and I can speak to personal experience. I know that is very difficult I have anxiety and depression personally, and what I did was not take care of myself whatsoever in terms of physically. So I would eat fast food, I would not exercise, and over the course of my recovery, I found something in kickboxing that I love to do, and that helped me lose over 60 pounds, and I've really made a difference in my mental health. So we are at NAMI Maryland, we were working on a pilot program called Healthy Hearts and Minds, knowing that those with mental illness die much sooner than their peers based on physical wellness. So that's definitely something critical to take care of yourself, because you are important and you are worthy of that self-care.
Absolutely. And sleep, I think getting a good amount of sleep, and as part of that schedule, staying on the, going to sleep at the same time, trying to wake up at the same time, all of that. It's very important.
Absolutely. So I do want to be respectful of our speakers and our attendees, and I know we're a little bit over. So we're going to end the webinar for today, but I do have our contact information up there. If you do have any questions or any concerns, please don't hesitate to reach out to us. So I just want to thank you for joining us. And again, this webinar has been recorded and it will be emailed to registrants tomorrow. The webinar will also be uploaded to our website at www.namimd.org for any individuals who were unable to register today. We hope that this webinar has been helpful for you this afternoon. And at the end of the webinar today, you will be asked to complete a short survey on the aspects of the webinar that you felt were helpful, could be improved, and what you would like to see in future webinars. Each person that completes the survey will be entered into a drawing to win a $25 Amazon gift card. This is only one webinar in a series of educational webinars that NAMI Maryland plans to host. This survey will help determine how NAMI Maryland can best support you during this time. Our next webinar in our depression series is entitled Beyond Treatment, Supports and Strategies. We will take place on Monday, March 22nd from 12 p.m. to 1 p.m. And Gabby will include this in the chat now for anyone who may wish to join us. By being an attendee of this webinar, you are also invited to join us for our NAMI Walks Your Way Maryland campaign. NAMI Walks is the nation's largest and most successful mental health awareness and fundraising campaign. NAMI Maryland has been involved in NAMI Walks since the very beginning, and we invite you to join us for what will no doubt be an incredible virtual experience. There are many ways you can make a difference with NAMI Walks. As a sponsor, a team captain, team member, or individual participant. However you participate, you'll be joining a national movement to reduce stigma, spread awareness, and support NAMI's mission here in our state. You can join us now at namiwalks.org/Maryland, and Gabby will also include that in the chat for you. We wish you all a safe and healthy rest of your week, and please do not hesitate to reach out to us if you should need any additional resources or support. Take care.